part 5. Okay, we have done 4 parts till now of NEET MDS 2021. Okay, so I'm starting with a disclaimer. Okay, these questions are done with a based off the recall only. Okay, they might not be the exact phrased questions that came up in the NEET exam, right? And not exactly all the options were reproduced. You know this because almost of you would have known this, because NBE does not give out the paper. This is only based on what recall that we have got from various. So please remember that, and this is only for those people who have attended, and for them it's just a recall as to okay, the answer will be direction. And for all other people who are going to take NEET MDS 2022, this is how probably your paper will be. So for each question concept, you have to listen and read and take it in that direction and go. If a question comes like this, how do you take it forward? So that is how we are going to plan this. That is why we planned these sessions in the first place. We have done 4 parts till now. So this is the 5th part. Okay, can we start with the questions? I'll be discussing the questions and simultaneously the answers, because I'm going to discuss a set of 30 questions now. So if there is any doubt, you can ping in the chat box. I'll see in the chat box and I'll reply to your doubt. But I'm not waiting for so much time for all of you to reply for answers from you guys, because it will take a lot of time. I'm going to keep discussing each question for a very long time. Okay, so can we start? Okay, we'll move on to the first question in this set. Okay, just see the question. A 33-year-old patient reports to the dental clinic for checkup. He has 4 filled teeth, 2 extracted teeth due to pericarditis, and chalky white spot lesions. Calculate the DMFT score. Okay, the options were 0, 6, 8, and 10. So moving on to the concept discussed for this question, it will be the DMFT index. Okay, the decayed, missing, and filled tooth index was given by Henry Klein, Carol Palmer, and Knudsen in 1938. This was the first time this DMFT index was introduced, after which it was revised twice in 1987. These are the combined criteria for the D, F, and M. Okay, I have put up the initial criteria and the modifications all in this slide. Okay, I'll just discuss what is important for this question. This patient, just see the question again. This patient has 4 filled teeth, 2 teeth extracted due to pericarditis, and 6 chalky white spot lesions. Okay, and it's a 33-year-old patient. Okay, so there's no decay. So this decay part itself we can omit for this question. Okay? For the filling, he has a permanent restoration in 2 teeth. So that will be counted. Again here, it's a chalky spot, meaning they are not being considered as decay. So that 6 chalky spots you have to omit. And he is 33 years old. So for individuals older than 33, the M component should comprise of all teeth missing due to reasons other than caries also. So using this calculation, we will take only these 4 filled teeth and 2 extracted teeth as positive, meaning 4 plus 2 is 6. So the answer is 6. So this will be the second question. Okay, this I think most of you got it right. Identify what structure does this histologic picture represent. Is it cardiac muscle, striated muscle, smooth muscle, or none of the above? Okay, so as we can see in the very clearly in the histologic picture that was given only, it is a smooth muscle. Okay, smooth muscles are spindle shaped cells with single nucleus. This is centrally located with sarcoplasm filled with the fibers, and the contractile elements, that is the actin and myosin filaments, are not arranged in myofibrils. That's why it is called smooth rather than striated, which is seen in both the striated and cardiac muscle type of muscles. Okay, so with this picture only, this picture is pathognomic of the smooth muscle. So you can go to the answer C and click the answer C for this. Okay, it was straightforward. Moving on to the next question. Identify a movable midline cyst of the head and neck. Here, this could have been paraphrased as a clinical based question, as a patient representing with a swelling in the midline neck region. But the concept here and the keyword here is the movable midline cyst. So, the options are thyroglossal, cervical lymphadenopathy, branchial cyst, and epidermoid. The answer is A, that is the thyroglossal duct cyst. Why do we say it is a thyroglossal duct cyst? That is what we want to know. Why is because it's one. We always go for the most common diagnosis when it comes. We don't go for the rare case. So the most common congenital neck cyst and pediatric mass will be thyroglossal. Located in midline, yes, okay. And this is a little about the thyroglossal cyst. Epithelial line cyst and occurs due to the normal obliteration of the thyroglossal duct doesn't occur. It doesn't occur. So it should occur at 8 to 10th gestational week, but then it doesn't occur. That's why the cyst is remaining. And patient presents with a painless rounded midline anterior neck swelling. Most cases, only if it is infected, it will have a warm red, and it is a classic swelling that will move with deglutition and also elevates on tongue protrusion. This is about the correct answer, but why we are telling is because branchial cyst is a congenital epithelial that mostly occurs in the lateral part, so it's not not branchial cyst. Again, epidermoid cyst is occurs from the hair follicle, and this can be in the central part or the midline, but then this does not move with deglutition or tongue movement, so this is not the answer. Finally, cervical lymphadenopathy can have varied etiologies. Okay, and most common will be the upper respiratory tract infection, and it will have a chronic presentation and again doesn't move. So it's none of the other three. For a differential diagnosis to consider in relation to the question, you have to understand what other swellings will move with deglutition. These will be first, we know the answer for this question, that is the thyroglossal cyst. Others are any other swelling related to thyroid or ectopic thyroid or subhyoid bursitis or laryngocele or pretracheal nodes fixed to trachea. Any doubts till now? Can we move on? Is my audio clear? I just know whether, and is there any? So other differential diagnosis for swellings include lymph nodes, inflammatory adenopathy, any malignancy. As I already told you, it would be any thyroid related swelling, parathyroid adenoma, laryngocele, ranula, epidermoid cyst, neurofibroma, cystic hygroma, or hemangiomas. Okay, these are the other midline swellings that can occur as another snippet of information in related to midline swelling. Okay, our diagnosis for the answer for the question is thyroglossal cyst. Will be there. So we'll move on to the next question. A forensic odontologist is involved in dental profiling. The keyword here is dental profiling. Okay, what is he performing? Is he performing reconstructive identification, comparative identification, oral autopsy, or positive identification? Here, question, the concept of this about the types of identification done for forensic studies, for forensic analysis. Okay, so this is of three types. The answer for this is that is reconstructive identification. Okay, first is what we do is a comparative identification, wherein have both the for the deceased patient, we have both pre and post-mortem records. If we have, what they do is they take an oral autopsy, then compare it to the pre-mortem records, and then come to a conclusion and then write a report as to whether the records of the particular person passed away matches with our autopsy report. Okay, with that we will say as either positive identification, negative identification, or probable identification, meaning we are identifying the patient using these two records, that is the previously available dental records and the oral autopsy report. Okay, that is why it is called comparative identification. Okay, but in cases where there is only circumstantial evidence and we don't have a clear indication as to who the patient is, who the person is, okay, who the deceased person is, and dental records are not traceable, three major criteria are taken into consideration, that is the descendant's ethnic origin, the gender, and age. Based on this only, the dental profiling or reconstructive identification. Okay, based on this, we give a provisional report saying this could have been the identity of the deceased, because we don't have any previous records that we can compare and match. Okay, so that is reconstructive identification, also known as dental profile. And the last will be done in case of mass disasters, where there will be mass lot of people who would have require identification. So in that we need to compare a lot of say the correct identity of the deceased in case of very severe disasters. That will be the last kind of dental identification. It is very difficult because happened and the sources that is there and the amount of records that we are able to create, but then that is another type of identification that can be done using forensic analysis. Okay, so moving on to the next question. A dentist is working on a HIV infected patient and he gets a needle prick injury. What would be the next step of action? Is it administer immunoglobulins, administer vaccine, give HIV prophylaxis, or wait for the HIV test results? The answer is C, that is give post-exposure prophylaxis. Okay. What we have to do if at the dental setup, the doctor is having a needle prick injury from a HIV positive patient. Okay, first what we do is the trauma site has to be washed immediately with soap and running water or very mild disinfectant. You should not rub the hand or the area where you have got the prick, or squeeze or use very strong solution to get more blood. We will squeeze and see, to just remove the thing that you are not supposed to do, and with no bleach or any strong disinfectant you should not use. After which a baseline HIV test has to be done for both the doctor and the patient in question. However, we don't wait for the test reports. Post exposure prophylaxis can start within 2 hours of the we will anyways give the notification that a needle prick has occurred in the hospital, right? In the hospital that we are attending, we will give a report saying that the person has contacted a needle prick injury. So that report has to be sent, and post exposure prophylaxis should be started as early as possible, preferably within 2 hours and not later than 24 hours after exposure. After which antiretroviral therapy also can be given, that is of two, the basic regimen and the expanded regimen. Basic regimen consists of zidovudine plus lamivudine or stavudine. Expanded regime is basic regime plus nelfenavir or ifenavir. Okay, these are given for 20. Okay, this is the basic management, immediate management that you do for a needle prick in the hospital setup. Can we move on to the next question? The next question is a direct question of pharmacology, but the only thing is that we want to know, we have to correctly identify what type of or class of drugs that they want, because all these are anti. Which of the following is an SNRA? The options are duloxetine, venlafaxine, tazepam, and fenfluramine. Okay. The correct answer is D. I'll tell you why. Okay. These are all serotonin based drugs. Okay. Where, see, SNRA was our question, meaning serotonin norepinephrine. There is only a minor difference between all these things. Serotonin norepinephrine reuptake inhibitors are SNRAs. SSRAs are selective serotonin reuptake inhibitors. And noradrenergic and specific serotonin antidepressant is NASSA. So just see what they have asked and reply. Okay. So if the question is on releasing agent, the answer would be D, that is the fenfluramine. If it is on reuptake inhibitors, it will either be duloxetine or venlafaxine. And if it is selective serotonin inhibitor, it would have been any of these class of agents, fluoxetine, fluoxamine, or paraxetin. These are examples. Okay, so based on which kind of antidepressant drug that we are using as serotonin, because all of these inhibit either they act through the mechanism of serotonin, they inhibit both serotonin receptors or noradrenergic reuptake, or just selectively serotonin, or help in increase the releasing of serotonin and norepinephrine in blood, thereby elevating the mood. These are all mood regulators, right? So this would be the direct question. So we'll move on to another clinical based question. A 46-year-old female, a denture wearer, that is the key point here, presents with a small growth with gradual onset on the tongue for 2 years. Identify the lesion. Okay, is it a papilloma, rotational fibroma, lipoma, or giant cell tumor? The answer would be traumatic fibroma. The key here is, see, the denture wearer. Okay. You should note the key points or key words that they give in each question. Okay. It could refer to either the etiology or the or the tests also, test done, diagnostic test, or the test results they have shown so much, so what has to be done. That will be how a clinical question will be faced. In this question, the key word is denture wearer. Okay, so why we are telling traumatic fibroma is because it can occur at any age, any site, yes, but then it's a slow painless growth long period of time. Okay, and then there is a chronic irritation, that's why there is a proliferation of the fibrous tissue. So that is why this question directly points to the diagnosis of B, that is the traumatic or irritational fibroma. Okay, additional points for traumatic fibroma is it can occur in two patterns, that is the radiating pattern or the circular pattern. When there is an increased trauma, it will occur as the radiating pattern, and when the trauma is very less, it can occur as the flexible small circular lesion. Why it's not any other option? Because papilloma, as we all know, is infection, cauliflower like growth. Okay, can also occur in the trunk, but then this is the key point for it. It's a viral infection and cauliflower like growth. Lipoma means linguolipomas are mostly asymptomatic, and they also like commonly will mimic only the presentation of traumatic irritational fibroma. There is no trigger factor for that. Here we have shown it's a denture error, right? So something like that, there could have been a sharp margin of a restoration or a cracked tooth in relation to where the growth is. If something is there, it will lead you to the answer of traumatic fibroma, or else you could give lipoma as a DDX. Okay, and finally, giant cell fibroma also very very commonly mimics these two lesions, that is traumatic fibroma and lipoma. Difference is in the histopathology. So far so clear? Okay, one of you guys are telling me that another option was oral what? Okay, like I told you before in the disclaimer, we are not very sure of all the options, right? Because we have got this from multiple sources. So we are giving the most probable thing and the most probable answer. Okay, what would be the most probable answer? Okay, even if oral what was an option, because of the presentation, see the presentation. Okay, it is a slow growing mass over a chronic period of time due to some kind of irritation, so probably this will only lead you to irritational fibroma. Okay, so that is why B, possibly B. We'll move on to next question. wherein pre-extraction records for vertical dimension includes all. What do you consider for pre-extraction records? This is a direct question, but then what do you consider for VD? That is the thing. Is it profile picture, profile radiograph, articulated cast? And I think most of you would have answered this correctly. The answer is tooth size and shape. Okay. Pre-extraction records are PERs. Okay, they are done for establishing the VD, that is the vertical dimension. Generally, we as dentists do it arbitrarily. Okay, but then for correct measurement, we can use this one of extraction record on as in it could be the diagnostic test or instruments like the dacometer, profile template, Willis gauge, or any orofacial device, and measurements made through the closest speaking space. Okay, with the physiologic rest position, photographs, and radiographs. These are all the common tools that are used for VD analysis. Here, tooth size and shape doesn't come into picture, so the probable answer is except, no, includes all except, so the except tooth size and shape. One second. If fibroma option is not there, then the correct option could be if a fibroma itself is not there, no, it could be lipoma or giant cell tumor. Okay, because both are chronic lesions. They will take a long time to develop and have similar presentation. See, the thing with papilloma alone has, out of the 4 options there, okay, papilloma only has the cauliflower like growth. Okay, others have almost a similar presentation and similar kind of features also. Okay, it's based on the other things that come along with it. For irritation fibroma, you have the irritation as a background, as some kind of denture or some tooth or filling or part of prostheses, clasp, something like that. So others, you don't even have any trigger. Okay, they are, because their etiologies are different, won't have this kind of a trigger. So they would have had some other point, maybe age or something like that, for in relation to the particular question. Okay, in particular lesion, because all these otherwise, or they could have given the histologic picture. Okay, with that only you can say, because the difference in all these three, lipoma is fat cell, giant cell tumor will have giant cells in addition to fibrous cells, irritational fibroma is only fibrous growth, so it will have more of fibroblasts and deposited collagen. So that's how you differentiate. It's only because of histopath, because you will do a biopsy. Even as a clinician, what we do is we take a biopsy. Okay, after we take clinical records, we do the biopsy, then we'll confirm the diagnosis only after we get the biopsy report. Understood? Okay, fine. So that is how you derive the answer. In this question, put the keyword as denture wearer. So that's why I'm saying with conviction that the answer would be B. Otherwise, all will have all 4 may have some. So if that is clear, we'll move to the next question. This is also done. We'll move to this. Identify the condition depicted in the thyroid scan below. This is the radionucleotide scan of the thyroid. Okay, so is it Graves' disease, carcinoma, nodule, or goiter? I think this also most of you would have got it correctly. This is the answer is Graves' disease. I'll tell you why it's Graves' disease. When we are doing radionucleotide tracing, no, based on the amount of iodine intake, if the radio tracer uptake is taken as positive or negative, okay, especially when it comes to hyper and hypothyroidism. If there is very less uptake, it directs to hypo. If there is very high uptake, it will direct to hyper. See, this is how the normal radionuclear scan of a normal thyroid will look. There is high uptake of radio tracer, so this directly points to Graves. Okay, so that is how we derive the answer of Graves. But we'll need to know the how other things will look other than normal. There will be decreased uptake in case of goiter, but in case of malignancy and nodules, no, it will appear as hot or cold nodules. Okay, even in thyroid, nodule will appear as a hot nodule. Malignancy most commonly can occur as cold nodule, but the final diagnosis of whether it's a malignancy not be given based on just radionucleotide scanning. That is one extra point that you need to note. Okay, we'll move on to the next question. Identify the antidote for iron poisoning. Okay, this also is correct. I think most of you would have answered, so I'll just quickly run through the answer. The answer is C, that is desfuroxamine. Okay, what we do for acute iron poisoning is the first critical thing that we see, like from a clinician's point of view, we are supposed to monitor vital signs and give IV fluids. Okay, then chelation is what is the mechanism of how DFO acts. Okay, we give a chelator which will bring out the excess iron within the human body. This DFO can be administered both as IV or as IM. Okay, and if there is no signs of shock, go ahead with only IM. No need to give IV infusion. Just go ahead with the IM injection. This antidote question, any other antidote for any other poison could have come. What options that we got back? Okay, from recall, I have put up for that. The toxicity also I have just put up as additional information. Okay, flumazenil is for benzodiazepine, toxin is for isoniazid, and protamine, as we all know, is for heparin. Okay, so if when it comes to this kinds of question, no, just have a run through or go through of all the poisons and what antidotes will be given for each kind of poisoning. Enough. Okay, this is pretty direct. We'll move on to the next question, wherein a 45-year-old male patient complains of mouth and neck pain and difficulty in swallowing for 3 days and has been. He also has reported progressive swelling in the neck and has an inability to open the mouth. Okay, meaning he has trismus. An infected third molar has been extracted 3 days previously. Identify the probable diagnosis. Okay, so see, one thing, it can't be, first we'll exclude osteomyelitis altogether. Okay, so it could be any of these things. Dry sockets, he started having lymph swellings. Okay, he started having lymph node involvement. So probably it's not dry socket. Okay, the one key thing about this question is it could be cellulitis or Ludwig's angina. Why I'm telling it is actually points to Ludwig's angina only. The patient is having Ludwig's angina, but why cellulitis is a bouncer here is because part of cellulitis. Okay, it is also considered to be a subset of cellulitis because it's a spreading infection in the face, in the head and neck region, a spreading infection in the face. Okay, so that comes under the bracket of cellulitis. So it could be A or C, but definitive diagnosis for this patient is Ludwig's angina. As we all know, it originates as a prequel to any kind of extraction or dental infection. Also, just dental infection can spread to the spaces and cause involvement of 3 spaces, as we all know, for Ludwig's angina, that is sublingual, submandibular, and submental space. That is why you are having this inability to open the mouth, extreme swelling in the neck, and they will have a very severe presentation. When it goes to this life threatening stage, you will have to do airway management and probably tracheostomy. Okay, so that is how you will save the patient. When it comes to the just an additional point on it's a polymicrobial infection involving both aerobic and non-aerobic species. Okay, okay, elevate, one of you is telling me that elevated tongue was mentioned. Yeah, good. I mean, elevated tongue is messy. That's clear shot, no? The patient has had an extraction previously. He is reporting 3 days later, spitting saliva, unable to open the mouth, severe swelling. Obviously, involvement of all 3 spaces directly to Ludwig's angina, no doubt at all. Okay, so we'll move on to the next question. A carpenter suffers an injury during work and a small part of his finger is cut. He is brought to the emergency ward. Identify the anesthetic required. Okay, this could have been put up as a different form also, paraphrased also, but we'll just see what kind of anesthetic can be used for this. See, it's an end artery. Ends of fingers and toes is end artery. So obviously the answer should lead to lignocaine without adrenaline. The correct answer is B. Okay, surgery, whenever we are doing we do it under local anesthesia. We don't bother about general anesthesia. Topical doesn't suffice, so we'll have to give LA. But then the only concept is we generally give LA for prolonging its effect. Adrenaline with LA is the common thing that we do, but then for prolonging the effect of the local anesthetic in question. Okay, so why we are not giving adrenaline here is because it's an end artery, and because of vasospasm and vascular constriction that adrenaline will cause at end artery, it can lead to necrosis. So we are supposed to use plain LA. That's the concept for this question. So the answer would be plain LA. If we are asking what anesthetic has to be given, it is plain LA. If we are asking what complication will occur, if you give adrenaline, it can lead to necrosis. Okay. But recent concepts and recent reviews have shown that this is not very common occurrence. It is okay, but if it is being monitored and given properly, dose of adrenaline can also suffice. There's a separate school of thought. I'm not supporting that school of thought. I'm just that there's a separate school of thought that says that that could also be a option. Okay, but a majority of us go with this belief that Novocaine without adrenaline should be done in case of end arteries. Okay, so that's the concept for this question. We'll move on to the next question. This is again a direct question. Mycobacterium with AIDS is dash. That is, which species of Mycobacterium associated with AIDS infection? Okay, here there will be a doubt regarding only these two options. These two are not in place. Okay, both are correct, but the most common species will be intracellular. Okay, the beauty or the what to say unfortunate thing about intracellular is it's an opportunistic pathogen only, and it doesn't have much of effect at all, and it doesn't have much pathogenicity at all. Okay, it doesn't do much at all, but it takes a big course when it comes to HIV infection. Okay, it is one of the most common opportunistic infections associated with HIV, and when it occurs in case of HIV patient, it will become very disseminated and have an increased count of the microbe within the patient's body. Okay. However, the patient will not have a lot of symptoms associated with this. The symptoms will be mild, and even this typical granulomas and the caseating necrosis we see in case of Mycobacterium tuberculosis, no, that will be a little less or subdued when it comes to this species, that is intracellular species. Okay. Okay, if there is an, I'm getting one more query. If there is another option, Del for iron poisoning, but DFO is the first drug of choice. So the answer would be DFO, desferrioxoxin. Okay. One second. Why is it not A? Like Sujay in the previous avium. One second. I'll just answer this. Okay. See, it's not A because it's an end artery, right? If you give adrenaline in end artery, the most common complication that you will get is necrosis. So you are not supposed to give adrenaline laced LA. You are supposed to plain LA. That's why it's not A. Okay. It's an end artery, fingertips. That's why they have told he has cut their fingertips. Remember that part of the question. Toes and fingertips, never give adrenaline with LA. This has been going on for years. The extra thing that I told you, that now there's a school of thought that can occur, is a recent concept, but then most of the physicians don't recommend that. Still gold standard that you are not supposed to give adrenaline with LA in case of end arteries, in case of toes and tips. Okay. So like I said, yeah, it causes necrosis. So you're not supposed to give adrenaline because vasospasm, no, we are giving adrenaline to increase its duration of action. Okay, but it's for that it is going to constrict the blood vessels. When it constricts blood vessels in end artery, obviously the next step will be necrosis only. Necrosis will occur. So that's why we are not giving. But by chance the options were what it will cause, it will obviously cause necrosis. It will not cause any other adverse effect. It will cause necrosis of the fingertip. So we are done with that question. So I had another comment for this question. There was some other option, Mycobacterium avium. Okay, Mycobacterium avium is again very rare. The only two significant species of Mycobacterium associated with AIDS or HIV is only intracellular and tuberculosis. So if only these two options were given, you would be doubtful for only these two. Any other species, just leave it off. Okay. So the out of which the most common one will be the intracellular. Okay, tuberculosis also occurs, but then little less than when it compared to the intracellular. So the option, and whatever be the option, the answer is straightforward. The species that is most commonly associated will be intracellular. Okay. If it is fine till now, we'll proceed with the rest of the questions. Okay. Any other doubts till what we discussed till now? Okay. No, but where there separate options? Bovis is rare. That's what I'm telling. So the answer is intracellular. Bovis is rare. Bovis occurs most commonly in cattle. They were derived from cattle. That's why it has the name Bovis. Moving on to the next question. A patient with renal failure presents with uremic carditis. What is the first line of treatment? Here, see the first line of treatment. That is the question. Okay. So, is it, are you going to increase the dose of diuretic, that is furosemide? Are you going to do dialysis? Is it linezolid or pericardectomy? The answer is dialysis. Why dialysis is? First, we try dialysis. Okay. That is the first line of for uremic pericarditis. Okay. So, first you try dialysis. And through studies, this 76 have derived through studies only. 76% of the patients respond to dialysis. Okay. Other than that, anti-inflammatory agents and steroids are given, but however, their success rate is limited. Okay. Anti-inflammatory agents will give a relief for pain, and steroids will obviously give positive effect, but then steroids have more of adverse effects than positive effects. So steroids are not first line of therapy. Okay. Then intravenous antibiotics have been tried. Of that, linezolid is the most common first choice drug of choice. Okay. If you don't have dialysis in the option though, the answer would be linezolid. It will not be dialysis. So the first drug of choice antibiotic for uremic pericarditis will be linezolid. If there is treatment failure by using dialysis, we'll go ahead with pericardiocentesis. Okay. And if there is, if we cannot wait for so long to see the patient's response and the start itself it's very severe, we start with pericardiocentesis. Okay. And pericardiectomy doesn't occur at all. It comes in the very last kind of option. Okay. It is only when it is too severe and nothing can be done, we'll remove the pericardial layer associate which is associated with the infection. Okay. So moving on to the next question. Commercially pure titanium is joined by the process of. There are two key things in this question. One thing is commercially pure titanium, meaning it's only titanium, no titanium alloy. The other thing is joined. There is no soldering, bracing. He is not given as to whether it is soldering, bracing, or welding. Okay. So, what could be the option? Here, there are two confusing things. So, spot welding doesn't occur. Okay. We don't do spot welding for titanium. It's either laser or furnace under vacuum. We'll discuss both the options. Okay. First, see the key point to be noted about pure titanium is it is very less tolerant to contamination. It is very difficult to do something with this particular metal without contamination. Okay. So your welding process or joining process should have minimal contamination. Mhm. For that, the first choice, I'm giving both the options as B and C, but I'm discussing in the order of preference. The first choice will be furnace or oven soldering, where you're doing it under vacuum. Okay. Second choice, wood and can be laser. Okay. Most alloys are done through laser. Titanium alloys for implants are done through laser. But however, if there is contamination, pure titanium joining will not be a proper process. So in that case, you will have to protect that environment with a gas like argon. Okay. So when we are doing that, we can do laser welding for even pure titanium. So that is why I have given both B and C as options. The order of preference first will be under vacuum, furnace welding under vacuum, or lasers. Okay. Lasers are most common. Yeah, that's what I was telling. Okay. Lasers are most common for welding of alloy. Okay. But you will have to maintain the environment with inert gases. We'll move on to the next question. Identify the disease associated with the depicted radiographic appearance? I think this is straightforward, but again there is one hitch in this option list. There are two diseases that are directly associated with the radiographic picture. It is a hair on end appearance, so both options will be right. Okay, beta thalassemia and sickle cell anemia show hair on end appearance. The other two are not related to the disease. Okay, so hair on end appearance occurs because the diploic space of the skull vault will appear in a way, and thickening of the trabeculae occurs as the expands. So as a result of which there is a perpendicular orientation of these trabeculae that looks like this hair on. The other conditions that are associated other than sickle cell anemia and thalassemia major would be hereditary spherocytosis, iron deficiency anemia, G6PD deficiencies or enzyme deficiencies, and neuroblastoma. Okay. So when these, see, if only one of these options were given, you can go ahead saying it could be thalassemia major or sickle cell anemia, like straight. If both were not given, if both are given, both can occur with equal predilection. Okay, both could be the correct option. So remember that. So we'll move on to the next question. What is the space maintainer of choice for bilateral molar loss in a 7-year-old child? Okay. I think with the options, band and loop and crown and loop, most commonly we do only unilaterally. We can use them by most commonly for unilateral molar loss. And the age is the question here. 7-year-old child is the age. So meaning after bilateral molar loss and central incisors have erupted. So I go directly with the option of lingual space maintenance. Okay. So bilateral space maintenance are to be done on both sides of the tooth. And out of the three most common bilateral space maintainers, that is the transpalatal, transpalatal, and lingual arch, we go ahead with lingual arch for this patient. Okay. After incisor eruption. That's why I put 7 years. I'll finish this and I'll reply to a query on beta thalassemia. Okay, age is 12. See, even if it's a severe form of thalassemia major, patient can survive with proper therapy. Patient can survive up to 12 years. It's not like hemophilia, right? So, beta thalassemia major can go ahead 12 years, no issues. Yeah. So, okay, coming back to this question again, the answer would be lingual space maintenance. Okay, and why? Because very young child, fixed only you don't want removable, you don't want the child to damage it or lose it. So that's why lingual arch space maintenance. So another, next one is another direct question. Fruity smell of breath in diabetes is due to which of the following agents? I think I don't need to explain this much. Ketones, diabetic ketoacidosis. Okay, because of increased production of ketones gives a fruity odor in breath. That's all. So identify, this is one of the other tricky questions that came up. Identify the are the supposed options. We'll discuss each material per se and then derive at the answer. Okay. The correct answer would be this polyvinyl chloride, but we'll discuss each option. First, acrylic, no? Acrylic is a good material when it comes to prostheses, but then there are two things. It's tacky, it will have the staining and dust collection. One more thing, it is liable to light and poor strength and durability in the long run. That is the problem with acrylic. Okay. And when it comes to silicones are most commonly being used for maxillofacial reconstruction, but it has poor tear strength and a little lifeless kind of appearance from its appearance. So its the application is a little limited. Okay. And chlorinated polyethylene are thermoplastic elastomas. They are the in thing now for maxillofacial prosthesis construction. So they are being taken up in a very big way for maxillofacial prosthesis construction. Okay. When it comes to these PVC polymers, no, they were used extensively because they were very easy to fabricate and they had a good uh, life. Okay, they were able to give a good prosthesis, but the only thing with this is hardening of the margins and discoloration will occur due to the plasticizer loss over time. Okay, we are talking about time, which will fade over time. Is because of this plasticizer loss, there will be discoloration and hardening of the margins. That is why the most probable answer for this would be PVs. Okay. Yes, if it was before incisor eruption, it would be bilateral Bantam loop, not lingual, because lingual is contraindicated in case of there is no, if the incisors have not erupted, you cannot put the lingual arch. Okay, bilateral Bantam loop will go. Okay, so we'll move on to the next question. A periodontist is planning for incisions in the palatal flap. Okay, for a pediatric patient, identify the radiographic structure. Okay, this may not be the actual picture, but this picture depicts gubernacular canal. So this is about the gubernacular canal and the cord. Okay, it's a remnant of the dental lamina which lies within the canal in the palatal aspects of anterior teeth. Okay, how it looks in the radiograph. General, it will look radiolucent and corticated tract or band will be very clearly visible. You can see in the picture. This radiolucent tract or band will be very clearly visible. Okay, and for primary teeth, no, it will extend from the superior aspect of impacted permanent teeth to the normal site of eruption will occur. And size will vary depending on what tooth we are talking. And morphology will be like it will be an uniform tract, but vary depending upon the location and the type of tooth. So we'll move on to the next question. Okay. Sawtooth retirage is a characteristic of which of the following? I think this is direct. Even if it has been rephrased or paraphrased as a clinical or a histologic question, the key word here would be sawtooth retirage. Okay, so that directly points us to lichen planus. So histologic features of lichen planus has been put up here. As we all know, it will be hyperkeratosis, acanthosis, sawtooth retirage, civet bodies or colloid bodies, and when this epithelial connective tissue junction is weakened, histologic clefts will form, resulting in Max Joseph spaces. Okay. If any of the, not only for lichen planus, for all vesiculobullous lesions and for all skin and dermatologic lesions, please note the keywords in histologic of all these skin diseases. Okay. If any of those are put up, just directly connected to the associated skin disease. Okay. Is my audio clear? Is the PPT showing up properly? Because getting a feedback that for all of you guys, are you able to hear me and is the PPT showing up properly? Sujay, please check your please check your net connection first because reference material. No, I have just put up key points for each thing. Okay, I've and anyways, I'm for some of you, I hear that the words are getting blurred in my presentation. I am anyway speaking on them. Okay, so don't worry. I am speaking on the key points also. Oh, okay. That's what I'm anyway speaking on them. Okay, so don't worry. I'm not exactly reading from the slide. I just put up this slide with points so that in case you want to or just see it again, let those words be there. That's why I have put up a lot of sentences. This is unlike me in my usual presentations, but since this is exam questions, I want you to see the options and the explanations correctly. Okay, so don't worry about the blurred part of this thing. I'm explaining the option, don't worry. because some of you are getting it clear, some of you are not. So please, for those who are not getting it clear, just check your net connection also once more. Okay, we'll move on to the next question. I'm reading out the question options and give you the answer. I'll explain the answer also, so don't worry. A patient's laboratory report shows a complete deficiency in the alpha L iruronidase enzyme. Identify one key presenting feature of his condition. Okay, is it corneal clouding, dural calcification, jaundice, or dysphagia? The key point here is this shows us that it is MPS, mucopolysaccharide deficiency. So the answer here would be A, corneal clouding. Okay, this is characteristic presentation of our Hurler syndrome. Okay, type of MPS 1. Okay, Hurler syndromes present. You all know the features of Hurler syndrome. Very briefly, I'll tell you. They will have skeletal abnormalities, cognitive impairment, heart disease, respiratory problems, hepatosplenomegaly. Okay, characteristic facies and reduced life expectancy. Okay, ocular manifestation that is related to MPS, any MPS in general and Hurler syndrome in particular will be corneal clouding first. Then retinal degeneration, optic disc swelling and optic nerve atrophy can occur with reduction in vision. Okay, why corneal clouding occurs? The underlying mechanism. I have put up the picture here of corneal clouding. The underlying mechanism will be accumulation, that is the glycosaminoglycans, because it's a mucopolysaccharide enzyme deficiency. The GAGs are getting accumulated in the corneal layers. They are even displacing the collagen fibrils that will normally be present in the stroma. As a result of this excess GAG storage, it affects the keratinocyte size and disrupts the stroma adjacent to it. Okay, leading to the characteristic clouding, okay, of the cornea. That is why corneal clouding will occur in case of Hurler syndrome. Oh, okay, you have done a lot with one of you are telling me you have done a lot of studying in the past, so you just want to listen. Okay, fine. I'll go ahead with the next question. I accept. Okay, a lot of revision for a long time now. Okay, for a child with profound intellect, what type of behavior management technique would you select? Is it sedation, tell, show, do, home, or modeling? Okay, the key word here in this question would be profound intellect. Okay, so that took key as to the answer, that is modeling. Okay, I'll tell you first why the others are not considered, then I'll tell you a little on modeling. Okay, for sedation, see, we are telling that the child is good enough and can understand commands and is having profound intellect, so you don't need to go ahead with sedation for him. And tell, show, do is for very anxious children for the first visit, uh, and for people like for a child where you have to literally explain what you are going to do. For any patient you are supposed to explain what you are going to do, but then based on how much the patient can get back from you, so for such a patient you will do tell, show, do. And home is hand over mouth. We don't do at all and rarely practiced for very adamant children. Okay, very uncooperative and adamant children we do home. So the most probable answer for this would be modeling, wherein we show the child. Okay, it could be either direct or indirect, that is, it could be possibly one of the other, probably the child's sibling also, one of the other children can be taken as a model and show like this is how you have to react to treatment, this is what will be done to you, this is the kind of treatment that you will undergo, see the caries is there, I'm going to fill the tooth, something like that, and then show how positive behavior will be there, like how you should behave, you will show them, and then the child will mimic it, the child will see the person. If it's a live model, no, live model could be another patient or could be even the child will mimic the behavior of the model. Or if it's not a live model, you can put filmed uh, content, or that need not be a person as such. It could be some kind of graphic representation or a video showing as to how dental treatment will occur and how the patient cooperates. Okay, even some kind of cartoon or something showing how a patient cooperates properly with dental treatment. So a highly intellectual child will see all this and exactly model. So it's good for us. The child will behave properly for our treatment. Okay. Hmm. Okay, intellectual deficit. Okay, if the question was intellectual deficit, yes, we could go with based on how much of intellectual deficit is there. Okay, whether the patient is able to see, that is what it's case by case kind of presentation. If the patient is able to respond to commands and is able to understand what we are telling, I think we can first go ahead with tell show do also. Okay, very slowly explain. Okay, what we are going to do, tell him, because you need the patient's confidence. Okay, this is as a clinician point of view, from a clinician's point of view, you need the patient's confidence for you to successfully complete the treatment. Okay, if he is able to accept and understand what you are telling, you can try tell show do first. But still, if you feel that the patient will not be able to cooperate and doesn't have intellect to even understand what you are trying to convey, you can go ahead. Would be the answer. Okay, theory related was asked. Okay, if the question is on theory related, it based on Bandura's principle. Okay, principle of social learning. The theory related is the theory of social learning. Okay, it's not anything else. If based on any other options that could have been given for the theory related is principle of social learning. Okay, if we are done with the question, this is the next question. What is the most common contagious disease in India? Okay, this answer would be TB. Why? Because out of the 10 most common causes of death in India, first contagious disease that comes, leave the cardiovascular diseases and respiratory diseases, tuberculosis tops. Okay, it's third in the list. So, tuberculosis is still considered to be the most common disease in India. Malaria comes a little later, so it's not malaria. Malaria is also one of the top 10 kind of morbid conditions in India, but then malaria ranks less than TB. Okay, when it comes to TB and malaria, it's TB. Coming to the next question. Perineural spread occurs in which of the following conditions? All of these are salivary gland tumors. So, which of the salivary gland tumors has this perineural spread? Again, this is histology based. Even if it has been phrased or paraphrased as a clinical question or with a histologic picture or with just the words saying histologic picture showed perineural spread, the answer should be adenoid cystic carcinoma. Okay, of all the salivary gland tumors, adenoid cystic carcinoma has this aggressive perineural invasion kind of presentation. Okay, and the key point to note here is the prognosis for the patient is also strictly dependent upon how much of perineural invasion has occurred. Okay, okay, one of you guys are telling me that another option was adenosquamous cell carcinoma. Even then, a correct answer would be adenoid cystic carcinoma. Okay, okay. Squamous cell carcinoma has perineural invasion, but out of adenoid cystic carcinoma and squamous cell carcinoma, you could go ahead with adenoid cystic carcinoma. Okay, next is another direct question. Soap bubble appearance is characteristic of. Okay, this could have been again, see, as I am telling you, this could have been again paraphrased as a radiographic picture also, but still the key essence of the question is soap bubble appearance only. Okay, soap bubble appearance is characteristic of giant cell tumor. Okay, there are other lesions that will cause this kind of presentation, but those are not part of our options. The other option, that osteosarcoma, Ewing sarcoma, fibrous dysplasia. Okay, so radiolucent multilocular lesion consisting of circular compartments of varying size. That is a description of soap bubble. Okay, other than giant cell granuloma, aneurysmal bone cyst is one of the most common DDX, and then one variant of ameloblastoma will have this appearance, and very rarely central hemangioma. Okay, if there was no option for, one second, I'll just finish this question and let you know. So from the, if giant cell tumor was the option, answer would be giant cell tumor. If any other thing option, these are the other DDX. There's no other DDX for soap bubble appearance. For osteosarcoma, it is the key thing is sunburst appearance. Ewing sarcoma is onion peel, and fibrous dysplasia is ground glass pattern. Okay. One of you guys have asked me to explain the previous question. The key word about the question is perineural spread. In however way it could have been paraphrased, it could have been disguised as a patient presenting with certain symptoms and showing perineural spread also, or with histo or whatever. There are only, like you guys said, see, I've included only salivary gland tumors in these options, okay, because we got feedback like that for this question. I have included only salivary gland tumors. Okay, so if salivary gland are not part of it, these in a another consideration, you can take squamous cell carcinoma as the thing. Okay, squamous cell carcinoma and adenoid cystic carcinoma both will have perineural spreads. Okay, when it comes to salivary gland tumors, the answer would be adenoid cystic carcinoma. Okay, if you didn't have this option, you can go ahead and squamous cell carcinoma, because squamous cell carcinoma in the long run can invade neural tissue. Okay, is it clear? Can we move on to the next question? Occlusive dressing with lignocaine and prilocaine. No, the straight, there is one more query that I'm getting. I'll answer this before we move forward. Okay. So, one more option in your end arteries question was occlusive dressing with lignocaine and prilocaine. Okay. But see, you have to see the thing that suits the most. Okay. If you are planning to do some kind of surgical intervention in that region, you will have to give local anesthesia. Okay. Because he has cut the finger based on his presentation. He has cut the finger, so you are supposed to do a surgical management there. You just cannot put a dressing. So the most suited option would be use plain LA. Okay, use plain LA. Then if only there was within quotes saying that it's only a minor injury, you can possibly go ahead with topical. But the question was clear. I think he said they have so told that the patient, sorry, it's a carpenter question. No, the person has cut his finger, so it would direct you to the answer of LA without adrenaline only. Okay, so we'll move forward with the next question. Again, this is about TNM staging. Okay, a 55-year-old male patient is diagnosed with T2N1M0 on the dorsum of the tongue. Identify the best suited treatment protocol. Okay, I have led the answer towards the question what I have given, because we are not very sure of what T is given, but still, okay, for T2, and first we'll go ahead with a recap of the TNM staging. I think you have all done enough revision of TNM staging. I'll just give the salient points that will lead to the answer. Okay, T1 will be less than 2 centimeter, T2 is 2 to 4, T3 is more than 4. Okay, 4A and 4B, moderately advanced and very advanced local invasion of the tissues. Regional lymph nodes. N1 is ipsilateral. Is single ipsilateral divided again into 2B and 2C. 2A will be single ipsilateral less than 3, more than 3, less than 6. 2B is more than 6. 2C is bilateral more than 6. N3 is metastasis of more than 6 dimensions. Okay, in the lymph node. M is M0 or M1, meaning there is yes or no for distant metastasis. Okay, the condition that is depicted here is T2N1, meaning stage 2. Okay, in that case, what we do is we'll do surgery along with radiotherapy. Okay, basics of cancer treatment: very mild stage 1 lesions, wide excision. Okay, and then biopsy, and just give a good margin for surgical therapy. I think we are good enough. Okay, for stage 2 lesions, it should be a combination of surgery and radiotherapy. Okay, along with neck dissection based on the lymph node involvement. For stage 3 and advanced, for grade 4 lesions, grading, that is third and fourth grades, you will have to combine all three, probably a part of surgery and chemo radiotherapy. Okay, okay, less than 2 centimeters. Yeah, that's why I have given as T. Okay, it should be T1 if it is less than 2 centimeters. Even if it is T1, no, we should know the nodal involvement. Oh, no nodal involvement means we can go ahead with wide excision with good margins. It was in the tongue, right? If wide excision with good margins would suffice for no nodal involvement. Okay. You need radiotherapy advanced cases where you suspect that you cannot remove that much of tissue and you want to combine it with neck dissection also with nodes. Okay. So if this is clear, we'll go to the next question. Hemianopia with macular sparing occurs most commonly in the case of cerebrovascular accidents. Identify the correct statement. Was there an optic nerve damage, optic tract damage, infarction of the occipital lobes, or none of the above? Okay. The concept for this question is only one thing. Okay. Hemianopia with macular sparing. This occurs most commonly. I have put the keyword here as cerebrovascular accident. Okay. This particular condition is synonymous with cerebrovascular occlusion in ischemic stroke patients. Okay. What happens is hemianopia with homonymous visual defect sparing the central visual field. Central visual field of the affected side is spared. That's why we are telling macular sparing. Okay. This occurs commonly in case of infarction of the occipital lobe. So the leading answer would be C, that is the occipital lobe is affected. Okay. Little more on why this sparing is the mechanism of macular sparing. There are two schools of thought for that. One is they say that there could be blood supply for the visual cortex. That is why the macular sparing occurs because of supply from both the middle and posterior. The other hypothesis is if there is an incomplete damage to the cortex, the same thing will occur. Okay, if there is an incomplete damage, there will be one part spared affected. Okay. So we'll move on to the next question. Identify the depicted instrument. Is it a tooth forceps, extraction forceps, retaining forceps, and ligature forceps? Okay. This is a rubber forceps. Okay. The most probable answer for this question would be tooth forceps. Why I'll tell you. First, I'll tell you what are rubber forceps. You would have already known and revised, but I'm just recapping the entire thing. Rubber forceps are used to carry the clamp to the tooth. Okay. And they work in the opposite direction. Like when just imagine the extraction forceps, when you bring the two ends of extraction forceps together, working ends also will come together. But here when you spread the two working of the forceps apart, when the handles are squeezed together, understood? That is when the handles are squeezed together, the working ends will move apart. This will help in taking the rubber clamp to the area of the tooth, and the area between the working end and the handle will have a sliding lock device. Okay, that will lock the handles in position when we are placing the clamp onto the tooth. And one more thing, they are toothed, but then they don't have very deep grooves in their design. Why? Because if they have very deep grooves, the clamp will go and get attached to the groove very in a very tight manner, where then we will not be able to place the clamp on and then remove the forceps. So there is no deep grooves associated with the design, and the types could be Brewer type, Washington type, or Ivory type. The other options are extraction forceps. We all know extraction forceps for surgical removal of tooth. Retaining forceps are used for retaining the detachable rings and the traction hooks for ortho treatment, and ligature forceps, as we all know, for placing ligatures. So this depicts ivory type of rubber forceps. So the most suited answer would be toothed forceps. Okay. We'll move on to the next question. See in which question in rubber forceps. No, they are not used for retention. They are used for placing the clamp onto the rubber dam. So that's why the most probable answer would be toothed forceps. Okay. We'll move on to the next question. A female patient, 60 years, presents with a complaint of pain in the upper left back tooth region with halitosis and nasal obstruction. The patient had undergone extraction of root piece in the same region a month back under local anesthesia. Identify, paraphrased in any other way, the key words for this: nasal obstruction, halitosis, previous history of extraction, okay, and upper. Okay, so this will lead to the first diagnosis of oro-antral fistula. Okay, it's not oro-nasal. Any of this won't occur. Nasal obstruction, so no dry socket. Extraction in the same region, so probably see oro-nasal and oro-antral first in only the type of communication. Oro-antral is to the sinus, nasal is to the nasal floor. So back tooth region. So not OAF is the most common diagnosis. Okay, most commonly OAF results when we are extracting the second and first maxillary molars close to the sinus. We are fracturing that thin piece of bone between the oral cavity and the sinus, so we are creating a direct communication between the oral cavity and the sinus. Okay, clinical features would be pain, for foul alteration in the voice, salty taste, okay, inability to blow the cheeks, and air shooting into the mouth while blowing the nose, and escape of fluids or liquids when we are having food. Okay. Diagnosis is through Vasalva manner. Okay, to see whether the sinus membrane, we can, when there's a communication, you will be able to see a part of the Schneiderian membrane moving, right? So we ask the patient to performs Vasalva's maneuver, a cough or something like that, we'll be able to see the membrane moving at the deepest part of the socket. So that shows that we have actually communicated the oral cavity and the sinus. So that's why we are able to see sinus membrane moving. Okay, long-term communication complication for this would be sinusitis. Long-term presence of oro-antral fistula, if not treated, okay, would lead to sinusitis. This is the overall picture of how we manage oro-antral fistula. Just a small recap of that. Okay, one, we can do with closure with flaps only, or use platelet-rich fibrin, or with bone grafts and membrane. Okay, or synthetic materials like titanium or hydroxyapatite, or very rarely lasers have been tried, alveolectomy has been tried. Okay, so with this we are actually done with the no mention of extraction. Okay, with this we are actually done with the set of 30 questions for today. Okay, if there was no mention of extraction, there would have been any other I'm just presuming, because we see the question was framed based on what feedback we got from students. Okay, so there would have been any leading question towards oro-antral fistula or communication. Is there any other leading what a keyword was there? Like, you guys are telling me that there was no history of extraction. So any other keyword is there, then only we will be able to freeze in on a diagnosis. Okay, whether it is sinusitis or no keyword. Okay. Then if you could go ahead with if there is no other keyword, it's not leading, it could go to maxillary sinusitis. Both will have equal predominance. That's what here. See, why I am not giving maxillary sinusitis as my primary diagnosis for this question is because I have put extraction. Okay, meaning there is a trigger for, see, in case of any fistula, no, there should be a trigger for the communication between, whether it's oro-antral or oro-nasal fistula, for communication between the oral cavity and the sinus or the nasal floor. Okay, if it is not there, you guys are right. If no question, if the question did not direct towards any of the communication types, the answer, first predominant answer would be C. Okay, would be maxillary sinusitis. Okay, so with this we are winding up this session. Any doubts? These are all, again I'm giving you a blanket disclaimer. These were done completely based on recall memory. Okay, these are all two. This is these were directed only at all you people, all you students, all those people who took the exam, to just see whether they have, like, what could have been the answer, whether you were in the right direction. Now they don't fret. Okay, all of you, please, I have good hopes that all of you would have really thought each question and given the correct answer. This is for all those people who have taken the exam on 16th. So we are getting the results on 31st, okay, at the end closure of this year and starting the new year. So please don't get upset or anything thinking what would have been the answer. Okay, they are telling this is the answer, I have marked it wrong or anything like that. So please don't worry about what would occur. Okay, you would have all given your best, so don't worry. Just to know the concepts and refresh these things, because even if you have taken the question, no, you will be seeing this for the rest of your life, because we are all clinicians in the end. All these concepts will be getting throughout our lifetime. Just as a recap, think like a recap. And for all those people who are not who are here and are not part of the batch that has taken the exam right now, if such a question comes, what you have to do, that is all. Okay, this is completely directed at you guys for students. That's all. This recap is only for students. Okay, so all the best. Be coming up with more videos in this regard. Okay, and all the best for all your results. Or thing. Okay, tumor is less than 2 centimeters, no node involvement. Okay, first priority will go to surgery. Okay, based on the location, I presume that it is in tongue. If we are able to do with good margins, we will go ahead with surgical resection first. Okay, that would be the answer. Okay, so if there is no doubt, we'll close this session. We'll be coming up with future discussions. The entire paper will be put up in the app also. Okay, and for all of you who have taken the exam, all the best. Okay? All the best. You will get a good rank. So don't fret. Don't worry about which answer is right, which A was right or B was right. You would have done your best at the time of the paper. Okay, all the best. Take care. Thank you so much. Thank you so much for patient listening. Okay.